Good morning, everybody. Welcome to Georgia Heart Grand Rounds. This program is brought to you by Georgia Heart Institute. Any financial relationships of the planners have been mitigated. Our speakers have no financial relationships with commercial interests. If you have a question for the presenters, please wait until the Q&A segment. The evaluation will be shared at the end of the program. If you're watching online, you may submit your questions in the Q&A section, and we'll read it aloud. Your evaluation link will be posted into the chat section, so be sure to check that section to get your evaluation. And now it's my pleasure to invite Dr. Aguilam up to introduce our first speaker.
It really gives me great pleasure to introduce Dr. Priya Dixit. She's one of our final year cardiology fellows, as many of you know, and one of our chief fellows here at the Northeast Georgia Medical Center, Georgia Heart Institute Cardiovascular Disease Fellowship. She's originally from India and completed her medical school and internship at Jawaharlal Nehru Medical College. Afterwards, she moved to Michigan, where she completed her internal medicine residency training at the Trinity Health Oakland Wayne State University residency program as a chief resident. She subsequently joined our fellowship as one of our inaugural class members, and we really appreciated her leadership and dedication to the field of cardiology, but also being an integral member of the leadership part of our fellowship program. She's very passionate about cardiogenic shock, which I'm sure you'll see in her presentation, and hemodynamics and mechanical circulatory support. And happy to announce come end of this academic year, she will be starting her interventional fellowship in Michigan. Please welcome on stage Dr. Dixit.
Good morning, everybody. Thank you, Dr. Aguilam, for that kind introduction. I do not have any disclosures. We'll start with the learning objectives. We want to enhance the knowledge of cardiogenic shock, explore temporary mechanical circulatory support options in patients presenting with cardiogenic shock, and learn the benefits of having a shock team and how it can improve clinical outcomes. Cardiogenic shock is a life-threatening condition which is characterized by cardiac pump dysfunction, which does result in end-organ hypoperfusion. And the optimal therapy for cardiogenic shock at this stage is still debatable, and the mortality rate remains high at around 50%. How do we define cardiogenic shock? A simple definition of it is patients who present with low cardiac index, which is less than 1.8 liters per minute per meter square without any support, or less than 2 or 2.2 liters per minute per meter square with support, and a systolic blood pressure of less than 90 millimeters of mercury. Now, this can be variable because we do see patients presenting with normotensive cardiogenic shock and low output state as well. Signs of systemic hypoperfusion is a big one, like elevated lactic acid in the absence of hypovolemia. The most common cause of cardiogenic shock in these patients is either when they present with acute myocardial infarction or acute decompensated heart failure. And we can have either LV dominant cardiogenic shock, RV dominant cardiogenic shock, or biventricular failure as well. Now, the mortality rate for cardiogenic shock complicating by just acute myocardial infarction is around 50 to 60%, and with acute decompensated heart failure is around 40%. So at this point, it does remain difficult to prove the therapeutic benefit of conventional treatments in heterogeneous patient population, as the trajectory of heart failure progression is pretty wide, with varying phenotypic presentation from either they present with minimal to no symptoms or even refractory end-stage heart failure. This is a good representation of when patients present with different types of cardiogenic shock, whether if they have RV dominant shock, usually their CVP is more than 14 and their PAPI is less than 1.5. For biventricular, their CVP and their wedge pressure is high and the PAPI is low. And for LV dominant, your CVP is usually normal, but your wedge pressures are high. A couple of years ago, SKY did, initiate the SKY shock stage, which goes from A to E, which basically represents and is an indication of the shock severity, and it comprises of one component of mortality risk prediction in patients who present with cardiogenic shock. But this has only been studied with acute myocardial infarction shock, along with the etiology and the phenotype that they present with. And as we can see that it classifies these patients from stage A to stage E, where stage A is patients who are at risk of having cardiogenic shock, and E is patients who have impending circulatory collapse or who have refractory shock. They also added a modifier of cardiac arrest. These are patients who come in with anoxic brain injury as well. This is a good algorithm which I found in one of the papers which was published by Dr. Geller at Circulation a couple of years ago, which does look at how we manage patient who presents with acute myocardial infarction, cardiogenic shock, and they subdivide these patients who are at risk of cardiogenic shock, who present with cardiogenic shock, and who present with cardiac arrest. As we can see in the first column, these are the patients who are at higher risk of cardiogenic shock. These are patients who have, who are elderlies, who have had history of anterior MI, tachycardic, or even hypotensive. At this point, going radial access is pretty reasonable, and we do assess LVDP to kind of know where we are going with in terms of whether they need escalation of support or not. If the PCI is complicated by hypotension, then we can start them on vasoactive medication, and putting in a PA catheter is reasonable at this point. If the LVEDP is normal in these patients, then you can definitely finish off the PCI, send them to the ICU for closer monitoring. But if that does not happen, if your LVEDP is high, and if the PA catheter does show signs concerning that patient is an impending shock, then we can consult shock team or escalate the support. If the patient is presenting with cardiogenic shock, just before doing the PCI, you can think about just going femoral access, because that's going to make things easier, where if the patient does need escalation of LV support or RV support, then you do have access on the get-go. As we can see, for LV predominant shock, it's reasonable for us to escalate with microaxial pump, balloon pump, or even consider VA ECMO in certain circumstances. And if you do have RV support, then we do have options for it. You do have microaxial pump for the right side. You have dual lumen cannula as well as VA ECMO. Now, if a patient presents with VT and VFib cardiac arrest, pre-PCI, these are highly selected patients where we can definitely choose to just go with VA ECMO, and we do have indications and contraindications for it, which we will go over in a couple of slides. Now, performing PCI of the culprit lesion intervention via radial approach is reasonable at this point, and post-PCI placing in a PA catheter is reasonable as well, just to look at the hemodynamics. That was a management of patients who present with acute myocardial infarction, and this is the management of patients who present with heart failure, cardiogenic shock. Now, we do assess cardiogenic shock profile severity. If your MAP is good, then we can start with vasodilators, inotropes initially, and then we can consider if the patient is a good candidate for balloon pump. If the signs and symptoms have improved, then we just continue the same treatment. If the patient's MAP is less than 65, then we can add vasopressors along with your inotropes. And the same thing, if they have improved, then just continue the same treatment. But if things are not changing, and if patient's having severe and refractory cardiogenic shock, then we can consult shock team if that's available. And then, like we discussed in the previous slide, depending on what kind of shock or what a part of the heart is involved, you can escalate for more support. Let's go over some temporary percutaneous devices which are available at our institution. For LV support, we do have intra-aortic balloon pump. We do have transvalvular continuous flow microaxial pump. For the RV support, we have dual lumen cannula, VA ECMO, and for biventricular support, we have VA ECMO. Let's go over a little bit about each of them. First, starting with intra-aortic balloon pump. This basically impacts cardiac output and coronary perfusion. What this does is that there is rapid deflation, which results in decrease in your afterload and increases your stroke volume. It also increases your peak systemic blood pressure, and earlier opening of your aortic valve, and a shorter LV isovolumetric contraction phase. So essentially what it's doing is that it's increasing afterload in inflation, but reducing your afterload with deflation. And as we can see over here that, you can actually trace it via your EKG as well. When you do have a balloon pump console, it gives you EKG trigger, it gives you arterial waveform as well as your IABP pressure. The one on red basically represents your arterial waveform, and you can see that there's no diacrotic notch, but that is represented by the inflation and deflation of the balloon pump in diastole, which is also represented by your balloon pump pressure, which is represented in blue. Now, there are two main components in this. It's a double lumen 7.5 to 8 French catheter and has a pump console. The most important complication includes stroke, limb ischemia, and thrombocytopenia. The contraindication for this is severe aortic regurgitation, aortic aneurysm, aortic dissection, and severe peripheral artery disease. As we can see that this basically does demonstrate the same thing where there's EKG triggered, there's your arterial waveform, and then there's your balloon pump waveform. You want to make sure that it is between your TP interval because sometimes you can either have early deflation, late inflation, early inflation, or late inflation as well. So you want to make sure that the waveform is exactly at your TP interval. Now, what's the evidence of utilizing this balloon pump in the literature for patients who present with cardiogenic shock? Unfortunately, it lacks reproducible evidence supporting reduction, especially in mortality. The most prominent trials which were done was IABP shock and IABP shock 2, which did reveal that there was no difference in mortality, hemodynamics, vasopressor requirements in patients who present specifically with acute myocardial infarction, cardiogenic shock, when compared with standard therapy alone. Now, data does suggest the potential utility of balloon pump specifically in patients with acute decompensated heart failure. For example, there was one retrospective study which compared hemodynamic responses of balloon pump in patients with and without acute myocardial infarction and as well as acute decompensated heart failure. Before the balloon pump insertion, the acute decompensated heart failure cardiogenic shock group had higher baseline wedge pressure compared to acute myocardial infarction. And after we put the balloon pump, they show that there was a nearly 5-fold greater augmentation in cardiac output, but in acute myocardial infarction cardiogenic shock, it did not show to improve any clinical outcomes. So there's definitely a need for larger randomized controlled trials for evaluating potential benefit of balloon pump in patients who present with acute decompensated more than acute myocardial infarction. The second one is continuous flow transvalvular microaxial pump, and there are three classes. Either you can have the microaxial pump, which basically give you 2.5 liter per minute support, 3.5 liter per minute, and 5 liter, which is also known as Impella 5.5. This, what it does is basically continuously draws blood from your LV via the inlet port, as we can see in the image, and it expels it into your ascending aorta via the outlet port. What it does is that this unloads your LV, decreasing your LV work and myocardial oxygen demand. It causes increase in your MAP and cardiac output and increases your systemic perfusion. This also decreases your wedge pressure, secondary to reduction in right ventricular afterload as well. The 2.5 and the CP usually is placed percutaneously, whereas your 5.5 requires surgical cut down, and the device is usually delivered through a Dacron side graft on the either axillary or your femoral artery. And all these three devices are also FDA approved for hemodynamic support in cardiogenic shock, and the 2.5 and the CP is also approved for patients with high-risk PCI. The components of this is usually use a 9 French catheter with a 14 French sheath. It does have a PERT system and it has an automated controller. The most common complication is at the access site, like bleeding, also limb ischemia. The contraindication for the use of microaxial pump is LV thrombus, moderate to severe aortic regurgitation, peripheral vascular disease, as well as mechanical aortic valve. Now, what's the evidence of utility of microaxial pump in the literature? The two main indication is patients who present with acute myocardial infarction and also who are undergoing high-risk PCI. There have been a lot of clinical trials which have shown good clinical outcomes in terms of mortality benefit as well in patients who present with acute myocardial infarction and cardiogenic shock. And the other indication can include ablation of VT, bridge to permanent LVAD placement, and severe aortic stenosis. The PROTECT trials were very important in terms of improving clinical outcomes and comparing the use of microaxial pump with either just standard therapy or balloon pump to see if these actually improve clinical outcomes, such as mortality in patients who undergo high-risk PCI, and they did. The most significant trial is your Danger Shock trial, which was published last year, which basically compared, it was a multi-center randomized trial with around 360 patients presenting with STEMI, receiving either microaxial flow pump and standard therapy versus standard therapy alone. And as we can see that the death from any cause, even at 180 days, was better in patients who actually had the microaxial pump along with standard therapy when compared to standard care alone. But the incidence of composite adverse events was higher in patients who underwent microaxial flow pump, and the need for undergoing renal replacement therapy was higher in patients who underwent microaxial flow pump. Now, coming to dual lumen cannula for RV support, basically this is inserted into the right internal jugular vein using percutaneous approach. When this is connected to a pump, basically it functions as a right ventricular mechanical circulatory support, and when you connect it to an oxygenator, it can serve as VV ECMO as well. And this was first used in man, which was described in 2016. Now, one lumen essentially serves as an inflow cannula and encompasses a series of inflow vents, which is positioned across the SVC into the RA. And the second lumen has a multifenestrated distal tip to deliver blood into the main pulmonary artery. The inflow cannula essentially drains blood from the right atrium into an extracorporeal centrifugal pump, which delivers blood back to the pulmonary artery. Essentially, what we are trying to do is we are trying to give the right ventricle some rest, and so we are bypassing that right ventricle indirectly into the PA through those two lumens. There are two versions of this. One is 29 to 31 French for the proximal lumen, which is your inflow cannula, and then 16 to 18.5 for the distal lumen, which is your outflow cannula. Now, the intended position for the outflow cannula is usually the main pulmonary artery because we are trying to bypass the right ventricle. And the way this acts is it reduces your preload, reduces your right atrial, right ventricular wall tension, decreases your microvascular resistance, and hence decreases your mechanical work and oxygen demand. This can deliver around 4 to 4.5 liters of flow per minute, and this is approved by the FDA for 6 days and up to 30 days by European Medicine Evaluation Agency. Over here, we usually implant the 31 French dual lumen cannula. The indication for this is anyone who's presenting and where we are concerned about acute right ventricular failure, which can be because of myocardial infarction, it can be because of post-LVAD transplantation, because of pulmonary embolism, post-heart transplantation, and also as a part of biventricular support. The most common complication is vascular injury, hemolysis, iatrogenic tricuspid regurgitation, pulmonary valve dysfunction, pericardial effusion, and SVC syndrome. The next one is extracorporeal membrane oxygenation. This is basically ECMO, which is a temporary mechanical circulatory support that can be used for cardiopulmonary support. We have two configurations. One is VV ECMO and one is VA, which we use for cardiogenic shock. The letters basically describe where the blood is being drained and subsequent where output is in relation to the body. The first letter is always drainage and the second letter is always output. Our most common percutaneous configuration for VA is the drainage via your right or the left common femoral vein, where the tip is in the SVC or your RA, and the perfusion cannula is accessed via your right and the left common femoral artery, where the tip is in your aorta. Now, the three main components, one is oxygenator, one is pump, and one is drainage. What this is essentially doing is it's increasing your afterload and stroke work without any reduction of LV wall stress. And venting is generally recommended, whereas you currently debated when to vent and when not to vent is not completely understood, but anticoagulation is definitely recommended. The complication of this is North-South or Harlequin syndrome, bleeding, infection, CVA, limb ischemia. North-South syndrome is basically a common consideration when you go through femoral artery cannulation, when the lungs are not adequately oxygenated. You have your deoxygenated blood come in through your LA, go in through your LV, and when you have your oxygenated blood going in through your perfusion cannula, they are unable to even cross your aortic arch, and that is what causes your cerebral hypoxemia. And this is usually seen when the lungs are not doing good, but the heart is doing good. Now, the evidence of VA ECMO is there are no randomized controlled trials, but these are definitely used because we have observational data which do suggest improved in clinical outcomes, including mortality. A couple of slides about a study that we did in our institution, which was presented at HFSA 2024 and was published in Journal of Cardiac Failure, where we looked at retrospective observational data and compared balloon pump with microaxial pump and seen if the phenotypes of these essentially have an impact on clinical outcomes. The hypothesis was that there was no difference when we used both of these for patients presenting with cardiogenic shock. We looked at patients from Jan 2020 to 2024. We used around 147 patients who were identified with cardiogenic shock 87 of them presented with myocardial infarction and 60 of them with heart failure. 50 of them had balloon pump and 95 of them had microaxial pump. And this included all the patients who had the 2.5, the CP, as well as the 5.5. The primary outcome in this was in-hospital mortality. The reason why we did this was there's no head-on study which basically compared balloon pump with microaxial pump. So I wanted to see if there is a specific subset of patients which can actually benefit with certain type of mechanical circulatory support. I know this is a busy slide, but essentially what we found out was that the in-hospital mortality for our institution was a lot lower compared to our national mortality for cardiogenic shock. We did have a mortality rate of 40.8%, where our national average is usually around 50 to 60%. There was an association between the type, that is your balloon pump versus microaxial pump, in hospital mortality. And what we saw, which was surprising, that patients with balloon pump had better outcomes compared to microaxial pump. And this was after we had actually done logistic regression and we had actually compared all the variables. So, but when assessing your cardiogenic shock mortality, when we looked at whether this benefited patients with acute myocardial infarction versus patients with just heart failure, it did not make any difference, and the variables or the numbers were not statistically significant. But the length of stay was higher in patients who presented or who had balloon pump in. Now, this basically, to our knowledge, there is no contemporary clinical trial which basically compares both balloon pump and microaxial pump. It is speculated that shock severity with corresponding selection bias led to increased mortality with microaxial pump, and the etiology of the cardiogenic shock registry did not correlate to statistically significant different mortality for us. Balloon pump having improved clinical outcomes compared to microaxial pump in this cohort is definitely thought-provoking and needs further study to optimally in a contemporary randomized controlled trial. So essentially what we are trying to say is that, balloon pump definitely helps in certain subset of patients, just don't throw it away. Now, just a couple of slides on cardiogenic shock team. We know that cardiogenic shock is a complex mix of medical, catheter-based surgical therapies used to treat cardiogenic shock, and management of these patients usually is multidisciplinary. So a lot of cases, you have subspecialists involved in this, like heart failure, transplant cardiology, interventional cardiology, critical care, cardiac surgery. These directly contribute to the care of patient, and they each offer a unique perspective and distinctive skill at bringing together each of these stakeholders into a formalized team with a clear organizational structure, thus holds a promise of building a collaborative effort, which also helps in streamlining care in delivery in these patients. These are the three initial institutions which actually developed cardiogenic shock team, and they came in with a collaborative. So employment of a cardiogenic shock definitely can lead to better outcomes, which have actually been shown in a lot of studies. It is definitely our goal to have a formal shock team here, and we are definitely working on that paradigm. Thank you.